The Washington Manual of Surgery podcast is based on the 9th edition of the best-selling Washington Manual of Surgery.
This podcast is meant to condense key topics from our manual into bite-sized episodes for your convenience. Now, on to this installment of the Washington Manual of Surgery podcast.
Hello, everyone, and welcome to the Washington Manual of Surgery podcast. We bring you everything you need to know about high-yield general surgery topics built for your just-in-time learning. My name is Catherine Zivanov. I'm a general surgery resident and will be your host for this episode. We are thrilled to have Dr. William Chapman Sr. here for part one of our discussion on surgical diseases of the liver.
Thanks, Catherine. It's great to be here today.
Dr. Chapman is an abdominal transplant and hepatobiliary surgeon here at Washington University in St. Louis, where he serves as the Eugene Bricker Endowed Chair of Surgery, the section chief of the Division of General Surgery, and the surgical director of the Transplant Center. Thanks for joining us today, Dr. Chapman. On today's episode, we'll focus on benign liver diseases. Let's start with a brief review of liver anatomy and physiology. Dr. Chapman, could you describe the blood supply to the liver and help us understand the different segments, sections, and lobes of the liver?
Sure, Catherine. You know, the liver's very unique and the only organ that has dual blood supply with both portal venous and hepatic arterial blood inflow. This can be very helpful in diagnosing liver masses and changes that occur in the liver on cross-sectional imaging, which is why we typically consider getting triple phase imaging with an arterial phase, a portal venous phase, and a delayed hepatic venous phase. So the next important consideration of liver anatomy is the segmental distribution within the liver. So the liver is divided into 8 segments, with segments 1 through 4 composing the left hemiliver and segments 5 through 8 composing the right hemiliver. Segments 2 and 3 make up the left lateral section. Segments 4A and 4B make up the left medial section. Segments 5 and 8 make up the right anterior section. And segments 6 and 7 make up the right posterior section. And then segment 1, also known as the caudate lobe, is a separate segment unto its own. The superior and inferior segments of the liver are separated by the right and left portal veins, and the sections of the liver are separated by the hepatic veins. These sections make up the basis for anatomical liver resection. So, for example, when a surgeon plans to do a left lateral sectionectomy, this involves resection of segments 2 and 3. A left hepatectomy involves resection of segments 2 and 3, 4A and 4B, and sometimes, depending on the circumstances, also resection of segment 1, or the caudate lobe. An extended left hepatectomy, or a left trisectionectomy, involves a left hepatectomy plus resection of segments 5 and 8.
Thanks for that explanation. We have a great image of those liver segments in our Manual of Surgery, as well as a diagram of the different hepatic resections. Let's move on now to a case scenario. A 35-year-old woman with no past medical or surgical history presents to your clinic after a non-contrasted CT scan obtained for workup of a kidney stone demonstrates a 3.5 centimeter solitary liver mass in segment 6. What are some of the things you'd like to know on history and physical, and what should trainees have on their differential for this patient?
Well, maybe surprisingly, incidental liver masses are more and more common today than even 10 or 15 years ago, with our increased use of imaging in general and increased sensitivity of the cross-sectional imaging we use, CT and MRI. We see these more and more commonly, especially with this increased use of imaging. Now, most incidentally found liver masses are benign, especially if the patient has no significant past medical history and is asymptomatic. But it is possible, and occasionally patients will present with an incidental mass that turns out to be a malignant tumor. So we think about incidental liver masses in three broad categories. First, benign liver masses. Second, primary hepatic malignancies. And last, metastatic liver tumors. Another distinction that we make with liver masses is to determine, is the mass cystic or solid? For simplicity, cystic masses can be divided into three broad categories. Most commonly, simple cysts, which are very common and don't require any treatment unless the patient is symptomatic. And this is true even when the cysts are quite large. Much more rarely, patients may have cystadenoma of the liver, and these have potential neoplastic growth. And so the cyst lining, the epithelial lining, needs to be completely resected. And finally, the cystic mass we rarely see, but sometimes see, is a cystadenocarcinoma, which requires a standard hepatic resection. Hepatic abscesses or other complex cysts can be present when there's a bacterial infection, an amoebic infection, or very rarely, at least in the Western world, a gonococcal cystic disease. But patients with hepatic abscess, any that I just mentioned, are much more likely to have symptoms. So that these patients aren't very commonly going to present with an asymptomatic cystic mass. Now, for benign liver masses, we think of three broad categories. First, hemangioma. These can be diagnosed solely based on imaging when there's a peripheral centripetal enhancement or T2 hyperintensity on MR imaging. These do not require biopsy or resection unless they are symptomatic, and that's very uncommon. Second, focal nodular hyperplasia. These are abnormal collections of all liver elements. So these include bile ducts. There's often a central fibrous scar, and these have homogeneous enhancement on the arterial phase imaging with that central stellate scar on delayed enhancement on MR imaging. Similar to hemangiomas, these do not require resection, they do not rupture, and they do not become malignant. So once the diagnosis is made in an asymptomatic patient, they require no further attention. The third broad category is hepatic adenoma, which can present complications or problems. So hepatic adenoma is a benign liver tumor made up of sheets of hepatocytes, and these have neoplastic potential, and they can rupture. On imaging, these present as a heterogeneous mass with hyperenhancement on the arterial phase and variable enhancement during the portal venous phase. We typically get concerned about hepatic adenoma when they reach a size of 5 centimeters or larger, unless they are symptomatic. We tell patients to stop taking oral contraceptives if they're on them and to avoid estrogens in the future. So to sort between these types of benign tumors and how patients present, we want to know, are there symptoms? Has there been fever, weight loss, or pain? We also want to know whether there's any personal or family history of liver disease or cancer in general. So you want to check for things like oral contraceptive use, travel, and drug or alcohol use.
That was a great overview of an approach to incidental liver masses, and there's definitely a lot of things that trainees should have on their differential. So the patient says that she hasn't noticed any abdominal pain since she passed her kidney stone. She also denies any fevers, chills, or weight loss. She has no personal or family history of liver disease or cancer, and her social history is unremarkable without any recent travel. What additional studies would you obtain at this time?
So the patient will need laboratory assessment, and that should include a CBC, a complete metabolic panel, coagulation studies, and a hepatitis panel as a start. Now, if there's concern for malignancy, we also check tumor markers, usually a CA19-9, which would be elevated in the setting of a pancreatic or biliary-based malignancy, CEA if there was potential concern for metastatic colorectal cancer, and an alpha-fetoprotein, which would be elevated in the setting of hepatocellular carcinoma or perhaps a gonadal malignancy. Patients with a liver mass should have a triple-phase contrasted cross-sectional imaging study, either a CT if their renal function is normal, or a contrasted MR, depending on local expertise.
And so, given the importance of contrasted cross-sectional imaging, can you elaborate on the role for a contrasted CT scan versus an MRI and the use of biliary contrast agents like Eovist?
So, Catherine, this is a good question and one that often arises. CT and MR are very similar imaging studies with similar sensitivity and specificity. MR imaging is slightly more sensitive than CTs, especially for small tumors. The sensitivity of MR is about 3 millimeters compared to about 5 millimeters for a thin-cut contrasted CT. This is not a big difference, but occasionally is important if when we're looking for small metastatic sites. Now, with MR imaging, you can also use biliary contrast agents that can be helpful. So, for example, with focal nodular hyperplasia, FNH, Eovist can be used to help distinguish the hepatic adenoma from other types of benign tumors. I think the biggest factor at play is local expertise, especially of the radiology group, who really can be quite helpful in interpreting results. So if you've got a strong MR group, as we do, we tend to favor MR. But I think in many places, CT is a preferred imaging technique by the radiology team, and that seems to be more common in those centers.
Thanks, Dr. Chapman. So getting back to our case scenario, the patient's labs were unremarkable, and a triple-phase CT scan demonstrates a 3.5 centimeter mass with peripheral centripetal enhancement progressing to confluence over time. What would you like to do for this patient?
So, Catherine, what you're describing sounds to me like a hemangioma. Given that the patient is asymptomatic and has a small mass, she does not need a biopsy or surgical intervention and really does not require further follow-up imaging. The main thing for this patient is for her to remember this and tell her family so that, for example, if she were in a car crash or had some other accident and had a CAT scan at the outside, let's say in an emergency room, and someone sees this mass, they need to know this is not new. This has been known about and does not require further intervention.
Great. Well, that wraps up our episode. Thanks so much, Dr. Chapman, for being with us today. We got through a lot of great information about benign surgical diseases of the liver. Stay tuned for part 2. And as always, if you'd like to learn more, you can check out a full review of this topic in our Washington Manual of Surgery.
We are Drs. Paul Wise
and Jeff Blatnick,
senior editors of the Washington Manual of Surgery. We'd like to thank the residents and faculty of the Department of Surgery at Washington University Medicine, and we'd especially like to thank our associate editors for this edition, Drs. Catherine Caldwell, Ina Chen, Bradley Kushner, Martha Bucky McGilvray, and Jorge Zarate Rodriguez.
We hope that you enjoyed this episode of the Washington Manual of Surgery podcast. For more comprehensive information in a brief outline format, check out the print and digital version of the Washington Manual of Surgery, published by Wolters Kluwer Health and Lippincott Williams and Wilkins. Please search online for the Washington Manual of Surgery 9th edition to purchase your copy of the manual.
To learn more about the educational opportunities available in the Department of Surgery, please search General Surgery Residency at Washington University School of Medicine in St. Louis.